Good evening, everyone, and thank you for joining us. This is a friendly reminder that the webinar will be starting in approximately 1 moment. Thank you. Hello, everyone. My name is Faye Knights, and I'm the Education Program Coordinator with Crohn's and Colitis Canada. I'm very pleased to have the opportunity to moderate today's webinar and to learn more information from our guest speakers, Dr. Anthony Otley and Kevin Ram. I'd like to start by welcoming everyone to the webinar and then outlining today's agenda. Today's webinar, Newly Diagnosed, Let's Talk About It, hosted by Crohn's and Colitis Canada, is made possible by an educational grant from AbbVie. Some of you may be new to webinars, so I'll quickly run through how you can ask questions and how they'll be answered. Right now, all participants are automatically muted, so everyone can hear the speakers, and so we can capture the webinar's recording without any interference. If you'd like to ask a question at any point during the webinar, simply look at the middle of your webinar box. You will see a chat box. Please type your question here. I will be presenting questions when the speakers have finished their presentations. I will read as many questions as possible during our Q&A period at the end of our webinar series. If you have a technical question, you can also type your question here, and we will follow up with you directly. Great, we're ready to get started. Crohn's and Colitis Canada, formerly known as the Crohn's and Colitis Foundation of Canada, CCFC for short, was established in 1974 by a group of concerned parents of children with Crohn's disease and ulcerative colitis. We are a national charity dedicated to finding treatments and cures for Crohn's and colitis, and to educate people with these diseases and the public. We want the general public to be aware of these chronic diseases and the role it takes on the nearly 250,000 Canadians living with Crohn's and colitis. We also want people living with these diseases to be well-resourced and educated as possible. Crohn's and Colitis Canada has funded over $88 million in research to date. That makes us one of the largest funders of Crohn's and colitis research in the world. We have more than 65,000 supporters, many of whom are actively involved in our 80 volunteer groups or chapters across Canada, and many of whom have joined us today. Today's webinar is part of Crohn's and Colitis Canada Youth Engagement and Education Programs, which includes the AbbVie IBD Scholarship, Camp Got to Go for children and teens with Crohn's and colitis, and this, our first ever youth-focused educational event. Our education materials cover a variety of medical, social, and psychological issues focused on Crohn's and colitis. We have brochures covering issues specific to children with Crohn's and colitis, ostomy care, medications, and many other topics. If you would like more information about Crohn's and Colitis Canada, please visit our website at crohnsandcolitis.ca. I'm pleased now to introduce you to our first guest speaker, Dr. Anthony Otley. Dr. Otley is the head of the Division of Gastroenterology and Nutrition at the IWK Health Center and a professor at the Department of Pediatrics at Dalhousie University, Halifax, Nova Scotia. Dr. Otley has been involved in the care of children and teens with Crohn's and colitis for over 20 years. With a special interest in transitioning from pediatrics to adult care, he is a big believer in the power of bringing kids and teens with Crohn's and colitis together, and what they can achieve when they act together for a common goal. With this in mind, Dr. Otley founded the first week-long camp for kids and teens with Crohn's and colitis in the Atlantic Province, held for the past 4 years at Brigadoon Village in the Annapolis Valley, Nova Scotia. Welcome, Dr. Otley.
Thanks, Faye. And these are just a list of my disclosures, and just to welcome everybody to this webinar. And so I'm going to start things off talking from my perspective as a physician that looks after children and teens with inflammatory bowel disease, and what happens when I'm faced with somebody newly diagnosed with inflammatory bowel disease. And after I'm finished, then Kevin's going to take over and firsthand tell you what it is like living with inflammatory bowel disease and that experience firsthand. Being hit like a ton of bricks, and I often get the sense that that's how many patients, families feel when a diagnosis of inflammatory bowel disease is made. Often people compare it to being given a diagnosis of cancer. But inflammatory bowel disease is a lifelong condition, and this can have a huge impact when this starts sinking into patients and their family. And it's at this point usually I try and focus them on 3 main things. Having inflammatory bowel disease doesn't mean that your life is shortened. People with inflammatory bowel disease live as long as other people without inflammatory bowel disease. The other thing is that the goal of our therapy, our treatment, now that we've made the diagnosis, is that you return to being well, that ideally you have no symptoms, and you get back to living your life. That's always our goal. And finally, that having a diagnosis of inflammatory bowel disease doesn't need to impact your life goals, whether it's your education or work goals. I had to change that in the last couple of years when I was reminded that it does mean you can't go in the military, because if you're in the military, you can't have a regular prescription medication, or at least that's what I've understood in speaking with my patients. So again, I think first those are the things that I focus on. But if I sit down with the patient and their family members, and while it may be phrased a little differently from one family to another, these are the 3 key questions I'm asked and I talk about when I'm speaking to a newly diagnosed patient. First, what is inflammatory bowel disease? How did I get it? And how do you treat it? And I'm going to take each of these in turn to go through my approach when I'm speaking with a family. So what is inflammatory bowel disease? So first I break that down into the component words. What is inflammation? And often bring people back to inflammation that's most obvious and apparent that you'd see on your arm, whether it's from a bug bite, an infection. And inflammation is simply when you have areas of redness, it may be sore, swollen, tender to the touch, and maybe warm also if you touch it with your hand. And if we look under a microscope, in this case, this is what happens when you get a splinter through the skin. You get a lot of activity happening, and inflammation happens when there is white blood cells that come to the area of inflammation. They release chemicals that draw more white blood cells to that area. And so you can imagine with all that activity, there is that swelling, that area of inflammation. So that's inflammation. And then our bowels, well, our bowels start in our mouth and end all the way at the bottom end. And so where the inflammation happens really impacts what symptoms you're going to present with. If you have inflammation in your large intestine, that most often presents with bloody diarrhea, often with pain associated with that diarrhea. If your inflammation is in the small intestine, you may have diarrhea, but that's not bloody. Pain may be a component or may not. And again, there's many different other aspects or symptoms that can be seen in somebody with ulcerative colitis or Crohn's disease. But in large part, it depends on where that inflammation is in the intestine. On the left is the picture we'd all like to see, and that's the appearance of a normal appearing colon without obvious inflammation. This is an appearance that we would see at the time of a scope test. And on the right is what we would or can see when there's inflammation at the time of endoscopy. And ideally, when we make the diagnosis and we start somebody on treatment, we want to get things back to the way they are on the left side when it looks normal. Even though we can't cure inflammatory bowel disease, we can treat it to get the disease into remission. So the other aspect is, I've talked about inflammatory bowel disease, but really that's two main headings, Crohn's disease or ulcerative colitis. Some people may have heard of a third, and that's called indeterminate colitis or IBD unclassified. And that last category, this IBD unclassified or indeterminate colitis, is at the time of diagnosis, the medical team, based on the results of the investigations or findings that because of these investigations, we can't pinhole it into either Crohn's disease or ulcerative colitis. It is one or the other, but at that beginning, we can't make that assessment. And it's usually over time that it becomes clear whether it's Crohn's disease or ulcerative colitis. And there are two different conditions. And with Crohn's disease, the hallmark is that it's inflammation that's through the full layer of the bowel that involves anywhere from the mouth to the anus. Not meaning that it's always in all those spots. Actually, it's usually discontinuous, meaning that it's in different spots. Compared to ulcerative colitis, which only involves the colon, the large intestine, and it's from the anus up in some patients all the way to the beginning of the large intestine. But not all patients have the whole colon involved when they have ulcerative colitis. And there are a number of other features that can tell us whether this is Crohn's disease or ulcerative colitis. And that can be important, and I'll talk a bit about that when we come to how do we treat inflammatory bowel disease. It's important to know, is it Crohn's disease or ulcerative colitis? Because while many treatments are shared, there are some key differences, and knowing what we're dealing with is important when we come to recommending a certain therapy. So the second question, how did I get it? How did inflammatory bowel disease happen to me? And the first thing I talk about is age, because the age piece is important. You'll see from this red graph that the peak of onset of inflammatory bowel disease is in the second and third decades of life. So as a pediatric gastroenterologist, I see that because most of patients that I see with inflammatory bowel disease are teenagers. But certainly as an adult gastroenterologist, they would see patients usually in their late teens or in the third decade of life as the most commonly presenting with inflammatory bowel disease. So age is a piece. This is a graph from information from the Hospital for Sick Children in Toronto. In red are patients with Crohn's disease, in green with ulcerative colitis. And on the bottom part of the graph, I'm not sure if this arrow will can be seen through the webinar, but this is age, so less than 5 years, 10, 12, 14 years of age, and this is simply the number of patients. So one thing you can see is age is key when we're trying to figure out the diagnosis, in that in young patients, ulcerative colitis in green is much more common than Crohn's disease. But as we get into the end of the first decade of life, this changes, and more patients have Crohn's disease diagnosed rather than ulcerative colitis. And often it's about 2/3 Crohn's, 1/3 ulcerative colitis. In younger patients, so in pediatric patients, boys diagnosed equal the number of girls diagnosed or close to that, whereas in adults it's often women who predominate over men in diagnoses. This is a graph that just shows that there are differences by age also within a condition. So if we just look at patients with ulcerative colitis, and if you're under 15, then how extensive the ulcerative colitis can vary. So pancolitis just means that the whole large bowel is involved, and that's about 50% of patients. Whereas if we look at this older cohort, so those who are 30 to 39 years of age, it's reversed, and most patients just have a limited amount of their colon involved, the rectum, which is the last part of the colon. I use this as an example just to say that while we call this condition ulcerative colitis, there are differences depending on the age at which someone's diagnosed. So the question I'm trying to answer at this point is, how did I get it? And I'm showing you this graph. In red are areas where IBD is very common in the world, in yellow where it's less common, and then this pale blue color where it's quite unusual. So you'll see that in many of the developed countries, IBD is quite common, whereas in some areas such as Africa, Southeast Asia, it is less common. Some thoughts are that parasitic infections may be more endemic in some of these areas, and that may be protective against inflammatory bowel disease. Or maybe it's an environmental exposure that we have in the developed world that increases our risk. The truth is we still really don't know the one cause or causes of inflammatory bowel disease. One theory, so we don't know that this is not proven yet, but one theory is that if we look at many different conditions that have an immune basis to them, Crohn's disease being one of them, but also other conditions like multiple sclerosis, type 1 diabetes, or asthma, and we look over time, over the last number of decades, we can see that there's been an increase in many of these conditions. So is there a common trigger, a common cause to why we're seeing more and more of these conditions? Sorry, it's not advancing. There we go. So in 2014, what we would say is there are three components to what causes somebody to develop inflammatory bowel disease. Part of it is genes or genetics, and we know in some individuals that can be a key factor, especially in the very young children diagnosed with inflammatory bowel disease. Genes seem to be particularly predominant, but often a family history does exist. So if I'm seeing a young teen and wondering, could they have inflammatory bowel disease to explain their abdominal pain? If they have a family member, a first-degree relative, a parent, a sibling who has inflammatory bowel disease, that does increase their risk. Now it depends if you're a cup half empty or half full kind of person. And although it increases your risks, it's not 100%. So if I am looking at a sibling or the offspring of somebody with inflammatory bowel disease, there's about a 10 to 15% risk that a family member may develop inflammatory bowel disease. But viewed the other way, there's a 90 to 95% chance that they won't. So genes are a component, but they're not everything. The other thing that through lots of research in the last several decades, we know that the immune system in the mucosa, or the lining of the intestine, is a key component which drives some people to develop inflammatory bowel disease. And the last component is this big one, the environment. The environment can be all sorts of things. One aspect, not the only one, but one aspect is bacteria. And there's been a lot of bacteria There's been a lot of interest over bacteria over the last several hundred years, as we know it to cause illness. But also, bacteria are a part of us. If one of the interesting facts is that we have more bacteria in our bodies than we have human cells. There are more gut bacteria in your intestines than there are human cells in your body. This is just putting it another way, looking at it, just putting out the numbers, the number of people in Canada, the number of human cells, and then the bacterial cells in your intestines. And so I think that's important to know because it makes sense then that bacteria have a huge influence or have the potential to influence expression of disease in an individual. And then the final aspect that people ask, I'm sorry, just trying to, can you advance the slide one? Is diet. Diet and the cause of inflammatory bowel disease. It makes intuitive sense that this is a condition that involves the intestine, so maybe it's something that we eat or something that we didn't eat that influences the development of this condition. And many families ask, did they eat too much junk food and that's why my child, or that's why I developed it? Or did I not eat enough healthy food? And different components of nutrition have been implicated as potential problems. But at this point, can we advance the slide? Thank you. At this point, there's still no definitive evidence to support diet as a cause for either Crohn's disease or ulcerative colitis. But many of the studies that have been used are at fault. Can we just go back one? Thanks. I would say stay tuned, however. Recently there's been some novel research that suggests that maybe we haven't fully addressed this or studied this in the proper way. So I think this is an area that's of interest, and I would expect that over the next few years we're going to hear more about nutrition as a component of both the cause but also the treatment for inflammatory bowel disease. So the final question then is, how do you treat it? How, when I've made the diagnosis of inflammatory bowel disease, what are the approaches that we can take to treat the inflammation and put the active inflammation into remission? I put this slide here for a number of reasons. I think the website pages capture the feeling that many patients, at least at some point during their life with inflammatory bowel disease, have, that IBD sucks. But it's also a caution to remember that anyone can put something on the internet, but that it may not be backed up by fact, and that you really need to protect yourself when you're searching the internet, although it's a powerful tool, that you seek out reliable sites. Certainly the Crohn's and Colitis website, it would be a great resource for validated, verifiable information. Again, when I'm sitting down with families, I often feel that I'm expected to be this guru, this fortune teller. I'm often asked, what can I expect for the future? What's my future with inflammatory bowel disease? How severe is my disease course going to be? And unfortunately, my crystal ball is foggy. We don't, in 2014, still have an ability to reliably know what someone's disease course is going to be like. That would be great if we could. If I could sit down with a patient and know that for the next 10, 15, 20 years, they were going to have mild symptoms, a mild disease course. Because if I knew that, then I would only potentially need to use milder therapies that had less risks associated with them for those patients. Whereas if I knew based on certain factors that this individual was going to have a more, or the potential to have a more severe disease course, then using stronger treatments up front with potentially greater risks may be warranted if we can change that future. So in 2014, we can't do that. But I want you to know that there's lots of research happening, both in pediatric patients as well as in adult patients, to try and get that information. We're involved, as well as other sites in North America, in a pediatric study, both for Crohn's disease and in ulcerative colitis, to try and figure out what those predictors. Is it something in the genetics, in the genes of the individual, something in the bacteria in the bowels, something about other components of how they present with inflammatory bowel disease that will predict over time what their disease course is. And if we can use some of those things that we could identify to personalize our recommendations. So, as I said, we don't yet have that ability. Let's go into the next slide. So the treatment goals for inflammatory bowel disease, and again, at this point I need to be more generic because what treatment options are offered to an individual depend on many different factors. Depend on, are they someone with ulcerative colitis or Crohn's disease, what their age is, where are they in their diagnosis? Are they just newly diagnosed, or have they had the condition for a number of years and already been exposed to and experienced different therapies? Where is their disease in their intestine? So many different factors, but in general, I would say these are common goals, whether you're a pediatric or an adult gastroenterologist, that you would have for your patient with inflammatory bowel disease. That we want to choose a therapy that's going to be the most effective to maximize the benefit, to get the disease in remission. And in doing so, we want to improve our patient's quality of life. We want them to feel better, be better, and do so minimizing the toxicity, the harm from the treatment itself. But also we want to make sure that we're doing a good enough job to keep the disease in remission. Can't follow it, that there's a pill that you take 4 times a day, next day you take it 3 times a day, and no one's going to remember that complicated things. We also need to appreciate that we all have busy lives, and especially when you're feeling better, it needs to be something that you can continue on. Don't be frightened by the next slide when it shows up. So I put this simply to show one aspect, of our understanding of inflammation. And you don't need to know the specifics, but you can see that there's a complicated model here of inflammation. And I show it because it's through research that we have a better understanding of the details of inflammation and how those differ in somebody with Crohn's disease or with ulcerative colitis. And with this kind of understanding, we can target our treatments more clearly and more directly. Next slide. So I'm going to show you 3 slides in turn. And again, the detail, oh no, go back one. The details aren't important. I think some of the things that I want you to do, this is slides that I borrowed from Dr. Walter Reinisch from McMaster University, who presented this at a meeting to the Crohn's and Colitis Foundation last year. And this shows in 2003 for ulcerative colitis the different drugs that were in research by drug companies to treat ulcerative colitis. And so these boxes just indicate the different ways that these different drugs were meant to target inflammation. So they target different aspects of inflammatory bowel disease. And if you look at this bullseye, so the outer ones are the ones that are furthest away from actual human study or use in the clinic. So in the middle are those drugs that are licensed and are available for use in patients. And just how drugs come to the clinic are through a complicated series of processes where initially they're studied in, actually probably phase 0 would be in animals, and then in phase 1 are healthy individuals, and then phase 2 and phase 3 are exposing them to patients with inflammatory bowel disease to see do they have the benefit. So in 2003, this is the map, and these are the sort of medications that were being explored. In yellow are those that are given through an IV or rectally, and in green those that were given by mouth. So if we go to the next slide, and we're just going to do this quickly, the next slide. So for in 2011, you can see just from a quick look, there's many more drugs that are in study, and now a number of drugs have made it to the clinic. And then next slide, that's 2011, and the next slide is 2013. And so you can see the sheer number of different forms of therapy, things that are in research, and again, many of them are still not near the to being in clinic and available to patients. But I think it is a time where in the next few years we're going to have many options, and so this gives many the potential that we're going to have more things that we can offer our patients as we search for a cure, because ultimately that is what we're trying to do, finding a cure. So when I'm sitting down and talking with a family, and again, this is regardless of the treatments, most of the treatments that we have benefit. We're using them because they've been shown to be of help in somebody with ulcerative colitis or Crohn's disease, but they all come with some risk. And when we're using drugs that impact the immune system, one of those common risks is a risk of causing cancer. And so we use different medications. We have, we're using them to treat the inflammation, and they can have potential risks of issues with infection, the risks of cancer, but also that they can help us to avoid using steroids to help promote growth if I'm talking about a teen with inflammatory bowel disease. But often all families or all the patients are hearing are that risk of cancer, and it is a hard thing to do. So I guess I put this slide here just to say that this is a process that has to happen over time, that you need to be informed. You need to talk with your medical team, whether it's the physician, the nurse, the pharmacist, to make sure that you have all the information you can to make a decision. Because most often there are options to what your therapy could be, and making sure that you understand the potential risks, but also the benefits, and putting those in context. I think the other thing I would say is that it's important as a medical practitioner that I realize that not all patients are the same. Again, I'm faced with patients that are pediatric or children or teens, but as an adult gastroenterologist, they will have younger adult patients as well as older adult patients. And the impact of different treatments, of different medicines, differ based on your age. And the risk for certain complications differs based on your age. And that is an important thing to remember. If I'm starting a young patient on a medication, and because this is a lifelong illness, they could have 30, 40, or longer years of exposure to that medication, and you need to be aware of that as the treating clinician. Is the reward worth the risk? And again, this just gets back to balancing the risks and the benefits, the risks and the rewards. And there's not always the one right answer. It really is an individual decision. Again, I think you need to be armed with as much information as you can gather through trusted resources, through the medical team, your family. also others with inflammatory bowel disease. But the one cautionary note I would say about that is if you're talking to someone else who has inflammatory bowel disease about their experience with a particular therapy, you need to remember that that's their experience, and that doesn't necessarily translate to what your experience will be. The final two slides about diet, or about treatment, I'm going to focus on diet. And again, if you go on the internet, you can find all sorts of recommendations, and there's all kinds of books that have been put out about this. Caution that, remember that anybody can put anything on the internet. I would say that in general, in a growing patient, and so children and teens with inflammatory bowel disease, we need to protect against restrictive diets during this critical period of growth and development. You are building or developing your bones up until about age 21, and so it's important that you get adequate sources of calcium and vitamin D. So if a restricted diet has been recommended to you, I think it's important to have a discussion with a dietitian to make sure that you're appropriately supplementing those nutrients that you're cutting out of your diet. So to end off, again back to this diagram which I showed you where there was places in the world with high prevalence or occurrence of inflammatory bowel disease and those where it was less likely. So one thought as to why it may be occurring less in areas in the developing world is, as I said, because in some of those areas parasites are endemic, are more common. And we know through research that if you have a parasitic infection, it causes a type of inflammatory response that's actually protective against somebody developing inflammatory bowel disease. So some researchers took this a step forward, or the next step. And this is not a human intestine. This is an animal intestine open, and these are a type of parasites. This is a pig whipworm called Trichuris suis. And so there was a study that researchers in the United States did in a small number of adult patients where they gave these patients, it's actually done also in patients with ulcerative colitis, they gave patients eggs that had this parasite, this whipworm, in the intestine. They would have grown and developed. And as shown by the results of this study, it seemed to be promising that a number of patients went into remission or at least had a response when they were exposed to this treatment. The CDI is just an activity, a measure of activity that we use in clinical studies to determine.
Thank you everyone for your patience. Unfortunately, we're going to have to continue on with the webinar, and we're going to start with our second portion. Dr. Otley will rejoin us for the Q&A period at the end of the webinar. Thank you, Dr. Otley, for that presentation. We now have our second speaker, Kevin Ram, who will share with us his personal story about living with ulcerative colitis and strategies he employs to communicating with his family, friends, and other people about the disease. Kevin Ram is a past winner of the AbbVie IBD Scholarship and an aspiring medical student and current microbiology student at the University of Victoria. Kevin was diagnosed with ulcerative colitis over 11 years ago, and after several hospitalizations, he made the decision to remove his colon. He lived with an ileostomy for 2 years, and then at 15 had the reversal to a J-pouch. He recently became the first individual with a J-pouch to reach the summit of Mount Kilimanjaro. Welcome, Kevin. Kevin, can you hear us?
Yeah, I can hear you.
There you are. Okay, we are ready for the webinar. Thank you for joining us today. Kevin, now to you.
All right, thank you so much. So thank you, Dr. Otley, for your information. That was really new, and I think I learned some new things as well, so that was great. If I can get the next slide, please. Awesome. So as I said, my name is Kevin, and I was a previous winner for the AbbVie IBD scholarship, and I'm currently at the University of Victoria studying microbiology with actually a focus on immunology, and I currently hold a minor in biology also at the university. So lots to do, lots of studying, and you actually caught me right in the middle of the tutorial, but I'd make time for this, absolutely. Next slide, please. So I'm here to kind of talk about my experience and how to cope with things. And then we'll talk about what your next steps are if you are a newly diagnosed patient. And I just want to stress really importantly that it does get better. I know there are always lots of ups and downs, especially if you are, a youth diagnosed with ulcerative or Crohn's or any form of IBD. It's always tough. But I'm here to kind of talk about it and let you know that I did it. And actually, on the previous slide, I forgot to mention, I was the first person with a J pouch to summit Mount Kilimanjaro in Africa. So nothing is impossible, even though you are living with a chronic illness. Things are still achievable and very well maintained. So I'm doing that kind of in my daily bread and daily skills and daily life, but anybody can. So I'd like to kind of give a brief history on my medical condition and what I did and how I got here. So if I could get the next slide, please. So I have ulcerative colitis. So ulcerative colitis, for those, I think Dr. Oatley might have gone over it, is inflammation in your large intestine, and more specifically on the inner lining. So if you take a look at that image there, it kind of shows the colon. And if you see the normal colon on top, it looks nice and fresh and clean. However, the colon on the bottom is saturated with ulcers, or it's saturated and it's damaged on the inside. And so essentially that is what ulcerative colitis is. Crohn's, however, does take things to the next level, and it kind of goes beyond the colon to any part of the digestive tract. But I'll leave more of those specifics to Dr. Oatley to address if anybody has questions. So I had an ileostomy. So when I was 12 years old, I was diagnosed with ulcerative colitis, and after going through many medications, trying things like prednisone, trying things like Asacol, and really trying everything that you possibly could, there came a point in time where things just stopped working. And of course, doctors don't recommend staying on prednisone for prolonged periods of time. So it did come down to a point where I had to go and opt in for an ileostomy. So an ileostomy, essentially what had happened was my large colon, as you can see there, was entirely removed. However, a small portion was left on the bottom part where the anus is. I lived with an ileostomy for about 2 years, and so they kind of take your small intestine from the inside of your gut and pull it out to the front of your abdomen. So you kind of have a little, what they call stoma, that sits on your belly, and you have an ostomy bag, and so all your waste is excreted into this bag. So you care and all that with that. However, after about 2 years of living with the ileostomy, my body had recovered enough for me to possibly go and live with, have a reconnection surgery called a J pouch. So we'll get into J pouches a little bit later, but essentially what a J pouch is that they take your small intestine, bring the stoma back in, and hook inside so it kind of makes a J shape. We'll go and take a look at a picture of what that looks like a little bit later, and it'll be a little bit more clear. But I live with what's called a J pouch now. As of today, and for the past couple of years, I've actually been medication-free. However, I have had to have a pretty, I don't want to say strict, but a pretty rigid diet regime. So that's how I keep on top of my health and how I keep on top of my diagnosis and my daily living. Overall, as was probably already mentioned, including my health is great. Like, I summited a mountain with no problems other than, of course, some climate sickness. But I did that mountain, and I never thought in my wildest dreams that I would do it. I did it with an organization called IDEAS, and they stand for Intestinal Disease Education and Awareness Society. So just a little quick brief history on me. Next slide, please. So living with ulcerative colitis. So I'm here to kind of talk to you about what it's like and how you can go about in your daily life, and how you can tell your friends and your family, and what you can do on your next step in kind of dealing and coping with the disease. So I know that the first step is always the hardest step, and it's discussing that with your friends and your family. I know family is a little bit easier to talk to because hopefully they are there with you every step of the way through the diagnosis, through the hospital visits, through the surgeries. But it's more hard to tell your friends, to tell your school, to tell your teachers or counselors, and things start to get a bit difficult there. The only way to live with ulcerative colitis is to ensure that others around you know that you have ulcerative colitis. It's my opinion anyway. So it was difficult to tell my friends, but essentially you do tell them and you give them somewhat of an education opportunity. So you teach them what's going on in your body. And it starts off by telling a couple friends, maybe your close friends, telling your best friend or your cousin or, people who are not in your immediate family. And eventually you'll get comfortable enough to start sharing that experience with everybody else so people know what you're going through. It's difficult to have your friends notice that you are away from school. If you're not coming to classes all the time and you're not looking too well, you need to tell them what's up, right? So just kind of sharing that experience so people know what you're going through. Living with ulcerative colitis doesn't ever mean that you're living with something alone. There are tons of people out there that are going through exactly what you're going through. And again, the best way to do it is to talk about things, is to support yourself and have others support you. I think when it comes down to schools and extracurriculars, that is definitely difficult. However, there are great organizations out there that can really help you. What I would recommend is talking to your school counselor or talking to a peer, who's someone who may be able to help you out. Tons of schools have opportunities for one-on-one tutoring where they can hire somebody out of your school board to come to your home and help you catch up on projects and help you catch up and stay up to date. For myself personally, I was living with ulcerative colitis and all these surgeries all throughout high school. However, I didn't let it impact my life in any way, and I ended up graduating on time and actually with honors. So it does take a bit of work. However, it's possible, and it's definitely doable and achievable. So in my recommendation, living with ulcerative colitis, you just always have to talk about things, not with yourself, not with your healthcare professional, but with everybody around you. And again, it does take time, but you're definitely able to achieve that. The way that I ended up getting really comfortable and talking about it was I actually went to a wonderful place called Camp Horizon. Can I get the next slide, please? So at Camp Horizon, as you can see there, I attended the camp as a youth that was diagnosed with ulcerative colitis, and I went to this camp called Camp Horizon. The name specifically was Camp Canada, and everybody in that picture has an ostomy. And so, I mean, we're a good-looking bunch, I would say, and if you take a look at that. And this was definitely a pivotal moment in my life, and it was revolutionary for me to kind of come out of my shell and talk about things with all of my peers. This picture specifically is when I became a counselor for the camp. So I went there as a youth, and I loved it so much that I came back and I worked there for 3 consecutive summers, working from a counselor up to a team leader. So everybody in this picture, again, as I mentioned, is living with an ostomy. So definitely very cool. And it was one way that I stepped out of my shell and started talking about my condition. So now I don't only talk about it with my peers, but I talk about it to everybody on this webinar. I talk about it at schools. I talk about it in meetings, in advocacy groups. So I'm very advocate on not only my ulcerative colitis and IBD in general, but on an education point of view and how you can teach other people about what's going on. However, most people said this is a very invisible disease because you can't really see it, but you can definitely feel it a lot of the times. So yeah, this was kind of a turning point for myself, was going to a camp and just being with people that I could talk about it with. Next slide, please. So as I mentioned, moving on to an ostomy was a very difficult decision, and it was a very difficult point in my life, and I'm sure it is very difficult for many of you. Some people have the choice to move to an ostomy, and others kind of don't. It's a do or die decision at that point. Moving to an ostomy is rough, and again, you need to make the right decision for yourself. But again, talking to healthcare professionals and as well talking to peers on how their transition to an ostomy was is the best way to kind of get into an experience that you will hopefully a decision that you'll hopefully make for yourself that will benefit you. So in moving on to an ostomy, there are tons of options out there. You need to make sure that you are placing a decision for yourself that's made well, and not just in having an ostomy, but the type of product that you're using as well. There are many types of ostomy products out there, so definitely talk to your nurse, your healthcare professional, and reach out to different companies as well. And they actually do send out free samples. So if you're ever wondering what it's like, reach out to a company, get a free sample, and try it on before you even get an ostomy to kind of get a feel for what is really going to be your style. So Moving to an ostomy again is difficult because then there comes that whole issue of readjusting your life to fit the needs of an ostomy. So I'm not going to sugarcoat things and say that it was easy because it was very difficult to move on to an ostomy. However, practice makes perfect. You're going to live with it. For the first little while, you're going to be at home, you're going to be ill, and that's your time to adjust to something like an ostomy to get used to it. Living with an ostomy, it's actually easier to hide than you think it is. And there is actually a very cool a very cool campaign going on right now that's called Bags Out, and it's kind of being funded by Ideas. And so you'll see pictures of people that have ostomies who just hang out with their bags out. So very cool, very fun campaign. But again, it's when you get comfortable enough to do that. And the best way is to meet other people and just talk about it and get used to things that way. So you'll find that there is power in people. And I would always recommend finding someone in your community, talking to your nurse, and getting hooked up with someone that can help you through things. So the decision is always yours, but it's always good to talk to people. And again, everybody's different, so it's good to kind of make your way, pave your way through things to see which is going to be the best option for you. So moving on to an ostomy, again, is difficult, but it is definitely a great decision I made for myself because it did help me in the long run, adjusting to things and helping ease my ulcerative colitis. So with the ostomy, the only best way, again, to live with it is to talk about people and practice. So if you have the option, definitely research that option very well and talk to people. Don't just read articles online, and get a personable experience. So next slide, please. And so this slide just kind of shows an ileostomy, essentially. So as you can see in the A, there was the colon. In B, the colon is removed, and you can see that this part of the small intestine has been pulled out to the outer body, and it now sticks on your abdomen. And so on part C, it has a side view, actually, and you can see that there is the ileostomy bag that sits just outside of your belly, and then your small intestine is poking out, and it's what's called a stoma. Next slide, please. So I have what's called a J pouch, and if we just go to the next slide, you can actually see what a J pouch looks like. So if you take a look, you can see that it does make a J, which is why they gave it a J pouch. Very original, I know, but I didn't make the name. However, I think it is quite fitting. As I mentioned earlier, they usually leave a portion of your anus that it can hook up to, but in that pouch is essentially where kind of all of your waste sits. The main drawback to not having a large intestine is, of course, water absorption and, of course, the extra space for your intestine. However, over time, your body will learn to adapt to those features. Now, it's never perfect, but it does do a very good job of kind of recognizing what the body needs to do and how to make the adjustments to give you what's best. So again, it's not easy. There are a ton of modifications on your life, such as your diet and how much water you drink, etc. But again, your body does do a good job of adapting. So the J pouch is here. Now, the J pouch is really great at, again, doing what the body would do normally. However, it does have situations where it can flare up at times. I usually have what's called pouchitis once a year, and so pouchitis is just a bit of an infection there. So you take some antibiotics, and it kind of goes away in 2 weeks with the antibiotics. Pouchitis is not in any way, shape, or form, for me personally, close to what a flare-up used to be. Pouchitis is very mild compared to that. But however, I would recommend, again, if you do look into that, kind of take a look at your options and see and talk to people before you end up making that reconnection surgery. So a J pouch comes after your ostomy, and it kind of hooks in, and J pouches are normally in patients who are able to get the reconnection surgery. So not everybody can go for a J pouch. So I live with a J pouch right now, and as I mentioned, it's very, very, you can live with it. It's easy to do that. So what I tell, I recently moved in with a bunch of new people, and I kind of went out the first day. I told all my roommates, and I said, hey, look, this is what I live with. This is, I go to the washroom a couple more times a day than normally. But again, it's just all about educating them and telling them what it's about so they know how to react and how to, cope with things when things do go sideways, if they ever do. The one drawback about a J pouch that I don't like is that it makes the noisy stomach, So what I like to say is that during, lectures especially, it sings the song of its people during lectures. So I kind of play it off and just go, oh, I'm hungry. But again, if you do educate people around you and tell them that, oh, it's just your day pouch going a little bit rowdy, they'll be able to understand and they'll know a little bit better. But again, just talk about it. Don't be embarrassed. Don't be ashamed about it. Don't be worried that someone is going to look at you. Just say that you're hungry. Laugh it off. I usually make jokes, like I mentioned already. But that is the one drawback that I would that I like to highlight. Overall, I'm a big advocate for going with Yasmi and going towards the J pouch. It worked well for me, and it worked well for other people that I know. However, everyone's body is different, so you definitely have to look into the research and know what you're going to get into before you get into it. So that is just kind of a brief history and just a little bit of a narrative of what I have gone through and what I've kind of done to give myself a boost and give myself an upper level on ulcerative colitis. In no way, shape, or form is it something easy to live with. And again, it is a very difficult thing to transition into and out of, especially if you're by yourself. So always, always talk to people, talk to your family, talk to friends, and reach out to your peers. Reach out to people who are going through this right now. There's way more people out there than you think that are going through it. And if you ever need to, send me an email and I can definitely chat with you and send you in the right direction about what to do. So thanks so much for listening. I am Kevin, not I was, I still am. I'm Kevin every day. But that was just my portion on Let's Talk About It and my experience.
Thank you, Kevin. Before we get started on the question and answer period, I wanted to remind everyone about November Crohn's and Colitis Awareness Month and our next webinar. Our next youth webinar is on Wednesday, October 22nd, and we will be discussing the topic of moving on up, transitioning in IBD. Here you'll learn about what you need to know when transitioning from pediatric care to adult care and about the resources available to you in post-secondary school. Also, our final youth webinar will take place on Wednesday, October 29th, and this will be on the topic of healthy living for healthy grades. Our expert speakers will have tips to ensure you have an A+ experience at school, including strategies to staying healthy. You can visit Crohn's and Colitis Canada.ca/webinar for more details and to register for the webinars. November is Crohn's and Colitis Awareness Month in Canada. Did you know that 1 in 150 Canadians have Crohn's disease or colitis? Visit crohnsandcolitis.ca for November events. And please follow us on Twitter at GetGutsyCanada and on Facebook at Crohn's and Colitis Canada so you can share your stories and read other people's stories too. And now on to our question and answer period. We are now opening up the floor for any questions you may have for either of our speakers. Okay, let's see here. We have one question that's come in to Dr. Otley. This is a question in regards to probiotics. The individual is asking, do you recommend the use of probiotics?
Thanks, Faye. So probiotics, I guess first how I would answer that is just to make sure everybody understands what probiotics are. I think the simplest way of describing probiotics is that they are good or healthy bacteria. They are often found in things like yogurts, and many health food stores and pharmacy carry many different types of probiotics. I talked earlier in my talk about the importance of bacteria, that we are more bacterial cells than we are human cells. And so people have looked at that to see, can we manipulate those bacteria to bring about a more healthy state? So probiotics have been looked at all sorts of things. They've been looked at to prevent the diarrhea when antibiotics are used, but also they've been looked at for the treatment of ulcerative colitis and Crohn's disease. And I would say they are the most common used alternative therapy in my patients as a pediatric gastroenterologist. But at this point, we still don't have any good research or studies that say a particular probiotic is effective to treat Crohn's disease or ulcerative colitis. the one possibility or one possible exception to that is a probiotic that's been studied in patients who have something called pouchitis. So Kevin spoke about having a J pouch, and one of the problems or complications people with a J pouch can run into is something called pouchitis, or inflammation in the pouch. And there are some studies about a particular probiotic that's been effective in some studies for treatment of pouchitis. So in short, while I may not specifically recommend probiotics, I think that they are safe, and I have many families who are interested in trying that, and I don't discourage it, but I can't recommend it because there's not the evidence or research to back it up at this point. But still a lot of interest, and there is research being done.
Excellent. Thank you, Dr. Otley. Okay, our next question is for Kevin. Is Camp Horizon open to people with Crohn's disease? And if so, what are the ages? Also, the question asks, is Camp Horizon, where is it located, and how can I find out more information about it?
Awesome. So great question. So Camp Horizon is located in Bragg Creek, Alberta, and it's actually about an hour north of Calgary. And so, yeah, Camp Horizon is open to individuals that have ostomies as well as individuals that have Crohn's or colitis. There's actually a separate camp as well just for individuals that don't want to go to the ostomy camp for whatever reason, and they want to go to a Crohn's or colitis camp. So there is kind of a mixture of both. This camp is open to youth ages 7 to 17. If you are older than 17, they also have a program called the CIT program, or LEAD, and that actually puts you into camp with other individuals with an ostomy or Crohn's or colitis, and you get essential training to become a counselor at that camp. So you're kind of a counselor in training, as I had mentioned. So there are actually also scholarships available, and they actually fund all of their campers both in-flight and registration fees to attend ostomy camp. And if you want to find information about that, I would Google Easter Seals Camp Horizon. Again, that's Google Easter Seals Camp Horizon. Go to their summer programming and look for the link for Camp Canada. So Camp Canada is what you want to go to, and you'll be able to find a couple contacts. You can email for information, and they can help set you up to attend camp. Most of the youth that attend camp from 7 right up until they're 17. So you'll see that you build pretty much a very lifelong and lasting relationship. So great question. And if you do get a shot to go to camp, I highly, highly recommend. If you cannot get any information or contact on them, you're welcome to get my information from either Helen or Faye through the CCFC.
And Kevin, I just echo that the importance or the benefit of attending camp. Crohn's and Colitis Canada has partnered with Janssen to develop a camp called Camp Gut to Go that took place for the first time this past summer in Nova Scotia with kids from across the Maritimes, Quebec, and Ontario. And it's a great opportunity. It's a week-long camp, and as you said, great time to build friendships that can last for years.
Excellent. Thank you, Kevin, and thank you, Dr. Otley. We have another question that's come in. This question is for Dr. Otley. What are your thoughts on processed food and the inflammation process?
Right. So as I said earlier, that there is interest, there's research trying to look at potential environmental triggers to inflammatory bowel disease. And different components of nutrition have been implicated or studied, and certainly different forms of producing food, such as processed food. But at this point, I would say that there's no clear evidence implicating processed food as a trigger to cause somebody's ulcerative colitis or Crohn's disease. That doesn't mean that an individual may find that their symptoms are worse when they eat more processed foods. That's a different thing, and again, not all people will have that experience. But to say that processed foods cause inflammation, I don't think we have enough information or research to support that. But again, it is something that's being looked into, and there is some diets that advocate avoidance of processed foods, and that's something I think we need to research and understand better.
Thank you, Dr. Otley. One last question here. We have a question in regards to MAP bacterium. If you are able to provide a little bit more information in regards to it, or any information surrounding it.
So that is a particular bacteria that has been implicated as a potential cause for Crohn's disease. I would say that it's controversial. There is research that would suggest, they've looked at a number of patients that have Crohn's disease and shown that there's been exposure to this particular bacteria, and some studies that would suggest if you treat with certain antibiotics that the individual will have remission of their symptoms, but there's also other research that has not found that. So it's a controversial topic. I think if we step back from just the MAP bacteria, but just talk about the search for a cause for inflammatory bowel disease, many people wondered, is there one bacteria or one organism that, is this an infection? Is this caused by an infection from a particular organism? And so MAP is just one of the different organisms that's been implicated, but to date, 2014, we would say still that there's no one organism that causes Crohn's disease or ulcerative colitis, but it's certainly something that is still being researched. So you need to, I think, keep abreast of those things, but at this point, it's not something that I would look for in one of my patients because I don't think there's the evidence to support that.
Okay, excellent. So there's no other questions. So this wraps up our webinar. I'd like to take the opportunity to let everyone know that we will be following up with you after the webinar via email to get your feedback and any suggestions you may have for future topics. I would like to thank everyone for being with us today and for the great speakers. I especially would like to thank Dr. Otley and Kevin Ram for taking the time out of their busy schedule to share their knowledge with us today. Also thank you to AbbVie for supporting this webinar. A recording will be made available for the public for download on our website at crohnsandcolitis.ca. Crohn's and Colitis Canada also hosts education symposiums across Canada every November, so please be sure to visit crohnsandcolitis.ca/education to find out more and to register. I encourage everyone to join us on Wednesday, October 22nd for our next webinar on Moving on Up Transitions in IBD, and on Wednesday, October 29th for our final webinar on Healthy Living for Healthy Grades. Please visit crohnsandcolitis.ca/webinar to register. Again, thank you very much for joining us tonight, and I hope we've helped answer some of your questions and bring more awareness to Crohn's disease and ulcerative colitis. And that conducts today's webinar. Thank you again.